Welcome to the Deep Dive, where we try to get straight to what you need to know.
Cutting through the noise.
Exactly. And today we're looking at a condition that's actually surprisingly common, but maybe doesn't get talked about enough day to day, G6PD deficiency.
Yeah, it's got some really interesting aspects. We've got some solid notes here, basically covering G6PD deficiency from A to Z definition, causes, management, the lot.
And our mission, as always, is to pull out the absolute must-know information for you. The stuff that helps you understand it, remember it.
You know, the high yield points. Because this is, believe it or not, the most common enzyme defect affecting red blood cells globally.
Which is kind of amazing when you think about it. Huge numbers. So let's dive in. What exactly is G6PD deficiency at its core?
Okay, so basically it's an inherited condition. It's genetic, and it affects your red blood cells.
Affects them how?
Well, the main consequence, the thing to really grasp, is that it makes red blood cells prone to breaking down that hemolysis. But, crucially, usually only when something specific triggers it.
Okay, so not all the time, but triggered.
Right, and you see it more often in people with Mediterranean or African ancestry. It's passed down in an X-linked recessive pattern.
X-linked recessive, got it. And this G6PD enzyme, what's its normal job? You mentioned it's key.
Yeah, think of G6PD glucose-6-phosphate dehydrogenase as like a vital protector for the red blood cell. Its main job is helping to produce two really important molecules, NADPH and glutathione.
NADPH and glutathione, what do they do?
So NADPH is essentially the fuel needed to recharge glutathione, and glutathione is the main antioxidant inside the red blood cell, neutralizing harmful oxidative stuff. Without enough working G6PD, you don't get enough NADPH.
So you can't recharge the glutathione shield?
Exactly. The antioxidant shield gets weak, and the red cells become super vulnerable to oxidative damage. And that's why G6PD deficiency is the #1 cause of something called non-spherocytic hemolytic anemia. The cells break, but they don't turn into those little sphere shapes like in some other conditions.
Okay, a vulnerable shield. So the underlying cause, the etiology, is that faulty gene then?
Precisely. It all comes down to a mutation in the G6PD gene itself.
There's a glitch in the code.
Yeah, a glitch that means either the enzyme isn't produced in sufficient amounts or the enzyme that is made just doesn't function properly. Either way, the red cell's defense is compromised.
Makes sense. Now, this is critical. What are those triggers? The risk factors that can set off the hemolysis.
Right. This is super important for anyone managing or living with G6PD deficiency. We can group them. First, obviously, is just inheriting the gene. That's the baseline risk.
Okay.
Then, a really big category, medications. Certain drugs are well-known culprits.
Ah, the drug triggers.
Right.
Let's get into those. Which ones are we talking about?
Okay, so antimalarials are definitely on the list. Primaquine is the classic example.
Primaquine?
Yeah. Though there's a little nuance there. Very low weekly doses, like 30 milligram for 8 weeks, might actually be tolerated by some people, particularly those of African or Asian descent. But you absolutely need expert hematology advice on that. It's not a simple decision.
Definitely needs caution. What else?
Then you've got certain antibiotics. Quinolones are a key group. Ciprofloxacin is one people might know.
The floxacins.
Right. Moxifloxacin, nalidixic acid, norfloxacin, ofloxacin. Basically, if it ends in floxacin, be cautious. Think Q for quinolones, questionable.
Good way to remember. Any other drug classes?
Sulfa drugs, that's another big group. Things like sulfonamides, like cotrimoxazole, although, interestingly, sulfadiazine seems less likely to cause problems. But you'd also include sulfasalazine and sulfonylureas, which are used for diabetes in that sulfa group. So S for sulfa and sensitivity.
Okay, primaquine, quinolones, sulfa drugs. Anything else specific?
Yep, a few others. Methylthioninium chloride, that's methylene blue. Nitrofurantoin, another antibiotic. Dapsone, and even prelocaine, which you find in EMLA cream used for numbing skin.
Wow, EMLA cream too.
Yeah.
That's quite a list. Are there drugs where the risk is less certain? Kind of a gray area?
Yeah, there are. Aspirin, for instance. Generally, doses up to 1 gram a day are considered safe, but higher doses might pose a risk. Chloroquine and quinine, other antimalarials, should be used carefully if someone has acute malaria and G6PD deficiency. Vitamin K analogs menadione, for example, carry a potential risk. And we mentioned sulfonylureas. They're in that possible risk category, too. It's more about being aware and cautious.
Got it. So medications are a huge trigger area. What about things that aren't drugs?
Infections are a big one. Just getting a significant infection can tip someone into a hemolytic crisis.
Any infection?
Pretty much any severe infection, yeah. And then there are specific foods. The classic one is fava beans,
Well-
also called broad beans.
Favism.
Exactly. That leads to favism, especially common in people with Mediterranean variants of G6PD deficiency. So F for fava and favism.
Good one.
Other things include diabetic ketoacidosis, DKA, and even acute kidney injury, which can paradoxically trigger a really severe hemolytic crisis.
Wow, okay. And does everyone react the same way?
No, definitely not. That's key. The severity of hemolysis really depends on the specific genetic variant the person has. There are hundreds. And also the dose or amount of the trigger they're exposed to. It's very variable.
Right, that makes sense. So let's go deeper into the mechanism, the pathophysiology. What's happening at the cellular level?
Okay. So we circle back to that weakened defense against oxidative stress. G6PD is part of a metabolic pathway called the pentose phosphate pathway, or PPP.
Right.
Its job in the PPP is generating that NADPH we talked about. And NADPH is absolutely essential for keeping glutathione in its active reduced state. Think of glutathione as the cell's primary antioxidant firefighter.
And NADPH is the water supply for the firefighter.
Kind of, yeah. Or maybe the energy bar that keeps the firefighter going. Without enough G6PD, you get less NADPH. Without enough NADPH, glutathione can't be regenerated effectively after it neutralizes an oxidant.
So the firefighter gets exhausted.
Exactly. The cell's defense against oxidative stress plummets. So when a trigger comes along, a drug, an infection, fava beans generating oxidants, the red cell just can't cope. The oxidants damage the hemoglobin and the cell membrane, leading to the cell being destroyed prematurely. That's hemolysis, causing anemia.
And you mentioned hundreds of variants. Does that change things clinically?
Massively. There are about 300 known variants, often just a single amino acid difference in the enzyme. These are grouped into classes, I to V, based on enzyme activity levels and clinical severity.
Can you quickly run through those classes?
Sure. Class I is the most severe. These people can have chronic hemolysis, even without an obvious trigger. Class 2 is also severe, less than 10% enzyme activity, very prone to triggered hemolysis. Class 3 is moderate, maybe 10–60% activity. They usually need a trigger for hemolysis. Class 4 is mild or no deficiency, 60–150% activity, often totally asymptomatic. And Class V actually has increased activity, so no deficiency.
So knowing the class helps predict the risk. Very useful. Now, if someone comes in with signs of hemolysis, how do you distinguish G6PD deficiency from other causes? What's the differential diagnosis?
Good question. Hemolytic anemia has lots of causes. You need to think broadly. Things like autoimmune hemolytic anemia, where antibodies attack red cells.
Right.
And the notes specifically highlight hereditary spherocytosis as an important one to compare against G6PD deficiency.
Okay, and the notes gave us a comparison. What are the key differences? Any quick memory aids?
Yeah, we can use that mnemonic approach again. For G6PC, think male Mid-African triggered crises, Heinz bodies. For hereditary spherocytosis, HSA, think both genders and European chronic plus crises spherocytes.
Let's break that down.
Okay.
Here.
Gender. G6PD is X-linked, so mostly males. HS affects both ethnicity. G6PD common in African, Mediterranean, SC, Asian descent. HS more in Northern Europeans. History. G6PD often has clear triggers, drugs, fava beans. HS is more of a chronic background, hemolysis with crises sometimes, blood film. During a G6PD crisis, look for Heinz bodies, those little blobs of denatured hemoglobin and bite cells. In HS, the characteristic cell is the spherocyte, a small, round, red cell.
And the diagnostic test.
Definitive test for G6PD is measuring the enzyme activity level. For HS, it's often an EMA binding test, which measures a specific membrane protein, so different tests confirm each condition.
That's a really clear comparison. Thanks.
Yeah.
Let's talk numbers epidemiology. How widespread is this?
It's very common globally. Estimates are around 400 million people affected worldwide.
Wow.
Yeah. In the UK, it's more prevalent in communities with ancestry from Africa, the Mediterranean, and Southeast Asia, maybe affecting around 1 in 10 males in those groups. The gene frequency varies hugely by region, from maybe 5% up to 25% in some areas.
It's mostly males, due to the X-linked thing.
Mostly males are affected clinically, yes, but women can be carriers. And if a woman inherits 2 copies of the faulty gene, one on each X chromosome, she can be affected too, known as being homozygous.
Right. And do most people know they have it?
Actually, no. The vast majority of individuals with G6PD deficiency are completely asymptomatic most of the time. They might never know unless they encounter a specific trigger.
And there's that link to malaria.
Yes, that's fascinating. The high prevalence in malaria endemic regions strongly suggests a protective advantage. It's thought that having G6PD deficiency offers some protection against severe malaria infection. The parasite has a harder time surviving in those red blood cells. It's a classic example of evolutionary balancing selection.
A trade-off for survival. Amazing. So if someone does become symptomatic during a hemolytic episode, what are the clinical features we'd see?
Well, you get the classic signs of rapid red cell breakdown and anemia. So pallor, looking pale, fatigue, feeling really tired and weak, shortness of breath. A key sign is dark urine, sometimes described as cola-colored. That's from hemoglobin spilling into the urine hemoglobinuria. And jaundice, the yellowing of the skin and eyes because of the buildup of bilirubin from the broken down red cells.
Dark urine and jaundice, classic hemolysis signs.
Exactly. And as we mentioned, significant jaundice in a newborn can be the first clue someone has G6PD deficiency. You're looking at intravascular hemolysis breakdown within the blood vessels. Over time, chronic low-level hemolysis or repeated episodes can lead to complications like gallstones due to all that extra bilirubin. And sometimes the spleen might become enlarged, splenomegaly, as it works harder to clear damaged cells.
And what about under the microscope? What does the blood film show during a crisis?
That's where you see those characteristic changes. Heinz bodies the little dots of damaged hemoglobin inside the cells. You need a special stain to see them, well, usually. And then bite cells or blister cells.
White cells.
Yeah, it looks like a bite has been taken out of the edge of the red cell. That happens when the spleen tries to remove the Heinz body. Blister cells have a sort of bubble on the edge. These are all signs of oxidative damage.
Okay. And when taking a history or examining someone?
Well, the history varies massively, like we said. Many are asymptomatic. Others might recall severe jaundice as a baby, or maybe a previous reaction after taking a specific medication, like an antibiotic or anti-malarial. On examination during an acute crisis, you're looking for pallor, jaundice, maybe checking if the spleen is palpable. They might also have tachycardia, a fast heart rate due to the anemia.
Right, putting the picture together. So how do we definitively diagnose it? What investigations are key?
The absolute gold standard, the definitive test, is the G6PD enzyme activity assay. You measure how well the enzyme is working in the patient's red blood cells.
That's the main one. What else supports the diagnosis or assesses the situation?
You'd start with basic bloods. A full blood count, FBC, will show the degree of anemia. A reticulocyte count is crucial. It's usually high during hemolysis, showing the bone marrow is trying hard to compensate by pumping out new red cells.
Okay.
The blood film, as we discussed, can show those bite cells and maybe Heinz bodies during an acute episode. You also measure markers of hemolysis. Bilirubin will be high, mostly unconjugated. Haptoglobin, a protein that binds free hemoglobin, will be low or absent, and LDH is often raised. You might check urine for hemoglobin.
And ruling out other things.
Yeah, important to exclude other causes. A direct Coombs test or direct antiglobulin test, DAT, should be negative. That helps rule out autoimmune hemolytic anemia. You'd also check renal function, UNEs, and liver function tests, LFTs, partly to assess any organ damage from the hemolysis and partly to rule out other causes of jaundice.
Any role for imaging?
Sometimes an abdominal ultrasound might be done, mainly to look for splenomegaly or to check for gallstones, which can be a long-term complication.
Okay, so enzyme assay is key, plus tests for hemolysis and to rule out alternatives. Once you have the diagnosis, what's the management strategy?
The absolute cornerstone of management is trigger avoidance. Educating the patient about the specific drugs, foods like fava beans, and the risk from infections is paramount. That's number one.
Avoid the triggers. What if a crisis happens anyway?
Then it's about supportive care, making sure the person is well hydrated, monitoring their blood counts and kidney function closely. In severe hemolytic episodes, blood transfusion might be necessary, but that decision needs careful consideration and usually specialist hematology advice.
Okay.
If severe hemolysis leads to acute kidney injury, the patient might even need temporary dialysis. Folic acid supplementation is generally recommended, especially if there's ongoing or chronic hemolysis, to support red blood cell production as the bone marrow is working overtime.
Folic acid. What about things like splenectomy?
Splenectomy is very rarely needed. It might be considered in very specific cases with severe chronic hemolysis that doesn't respond to other measures, but it's definitely not routine.
And any other specific things to avoid?
Yes, naphthalene exposure should be avoided. That's the chemical in traditional mothballs. It can be a potent trigger.
Mothballs, right. What about newborns with jaundice?
For significant neonatal jaundice due to G6PD deficiency, especially in premature babies, the main goal is to prevent bilirubin levels getting dangerously high and causing brain damage, kernicterus. This might involve intensive phototherapy or, in severe cases, an exchange transfusion.
So management really tailored to the situation. Avoidance first, then support. What's the general outlook, the prognosis?
Overall, the prognosis is generally very good, provided known triggers are avoided and any complications are managed promptly. Most people live completely normal lives.
That's reassuring.
The main serious risk is that kernicterus in newborns if severe jaundice isn't treated effectively. Otherwise, the long-term outcome really depends on the severity of the enzyme deficiency. Someone with a class I variant might have more ongoing issues than someone with class 3 or 5.
Are there any other potential long-term issues mentioned?
Well, in very, very severe deficiency variants, class 1, there can sometimes be associated problems with neutrophil function, potentially leading to something like chronic granulomatous disease, but that's rare. The notes also mention that prophylactic phenobarbital, sometimes used for neonatal jaundice, isn't helpful specifically for G6PD deficient babies. And there doesn't seem to be a definite link between G6PD deficiency and developing cataracts.
Okay, so mostly good with caution. What are the main complications to be aware of if things do go wrong?
The big ones stem from severe hemolysis. Acute kidney injury is a serious risk if the breakdown of red cells is massive and overwhelms the kidneys.
Right.
Gallstones are a more chronic complication resulting from the persistently high bilirubin levels. And while rare, a very severe acute hemolytic crisis, perhaps from a large exposure to a strong trigger, can potentially be life-threatening.
Okay, AKI, gallstones, and those rare severe crises. So wrapping up this deep dive on G6PD deficiency, it's this inherited condition, makes red blood cells fragile under oxidative stress,
Triggered by certain drugs, infections, fava beans.
leading to hemolysis, anemia, jaundice, but hugely variable in severity.
Exactly. And the key is knowing about it, avoiding those triggers, and managing episodes supportively if they happen. Awareness is crucial.
It really is. And it makes you think, doesn't it? Considering how common it is globally, and that link to malaria protection, how does understanding genetic variations like this really shape public health approaches in different parts of the world? Something to ponder.
Definitely food for thought.
Well, if you want to reinforce your knowledge on G6PD deficiency or revise loads of other crucial MSRA topics, definitely check out PathMSRA.com.
And there's also freemsra.com for, well, free resources too, both excellent for revision.
Absolutely. Thanks for joining us on the deep dive today. We hope this breakdown of G6PD deficiency was clear and helpful.
Catch you next time.